Okay, the clocks tick round to 6:30, so welcome to everyone, and many thanks to the ARCaRe team who are going to talk to us tonight around the community respiratory service and the home oxygen service and an update in the COVID world. We also have Richard Singh, one of the consultant respiratory team from the Royal London, who I'm sure many of you will know from coming out into the community and running the community respiratory MDTs. And Richard is going to talk a little bit at the end around the post-COVID secondary care clinic setup and give us some tips about that. So without any further ado, welcome to Jane, Charlotte and Ruth, and please take us away.
Oh, thank you very much, and thank you for the opportunity to come and just share some of our thoughts and obviously hear some thoughts back around this difficult time. It will be, as you said, Phil, a three-man act. So there's myself, if you don't know me, the clinical lead for ARCaRe.
I'm Charlotte Francis. I'm the home oxygen service lead for ARCaRe in Tower Hamlets.
And I'm Ruth Allen, the clinical psychologist.
Okay, so next slide. Okay, so just a brief overview of what we're hoping to cover, and we have incorporated a few breaks, which might be good opportunities to ask questions, or we can have discussion or whatever. So we wanted to set the scene about our service and what we've been doing during this period, just so that everybody is aware and you'll know which services to continue accessing. Also to go over a little bit about what we are seeing and what our experience has been. I think clinically, we're seeing what we expected, but maybe not in the volume that we thought we would see initially. We're going to update on home oxygen, which is crucial with this, particularly with this group of patients. So as you know, Charlotte is our home oxygen practitioner for Tower Hamlets. We've got a few tips towards the end of things that perhaps you could use when managing and supporting patients with symptoms in the community. So just a few quick tips around what you might advise patients. And then last but by no means least, just thinking about the psychological perspectives of patients who've had COVID, and also Ruth will cover that. And then, yes, again, time for questions and answers. Okay, so our service and what we offer and how have we adapted it. So I think we've already alluded to the fact that we've all been in the position of having to think about services and how we can alter them at very short notice. And that indeed is what we've done in ARCaRe. We've altered our hours of work so that we now offer an 8 to 6 service, 7 days a week. It used to be shorter at weekends. And also we've worked out a rota system, so we now have enhanced staffing at weekends, so we've got better capacity if we need to do more work in the community at weekends. Previously it was just the one person. Diagnostic spirometry is on hold as per the ARCP guidelines, but that is likely to change in the not too distant future, leading on from ERS guidance. So at the moment, anyone referred for diagnostic spirometry is on a waiting list. It's not huge, so I imagine that once we are able to start the service up, when we do start the service up, I'm hopeful that although we'll have to work differently, that we'll be able to get through that workload reasonably quickly. Pulmonary rehabilitation was suspended in mid-March. It did coincide with QOF, so at that point we were getting inundated with new referrals. So we have now more than 200 patients on the waiting list, which isn't great news. But what we've done with the patients who are halfway through a course is that we've continued to contact them and to continue to support them through the exercise that they're continuing with at home. And we're hoping that we may be able to complete some of those patients, although doing outcome measures at the end might be a challenge. The patients who are sitting on the waiting list, we have telephoned each of them, and we've also sent them a letter out explaining what the situation is currently. Our plan is to recontact them in 4 to 6 weeks, because we're aware that the longer the gap from referral to offering an appointment for an assessment, the more that dropout that we'll get. So we're trying to keep patients on board, and we will be looking at some point at whether we can do some assessments of those patients in a more virtual way. And we've also signposted them to other resources of information that are available. In terms of face-to-face contact, we have followed the guidance, and wherever practicable, we have avoided face-to-face contact. But that's not always possible, so in which case we've taken the necessary precautions and continue to see patients out in the community. Admission, avoidance and supported discharge has continued as normal, but referrals into admission avoidance have been extremely quiet. The last week we've had a few more, but it's been very, very quiet. So we'll maybe pick brains later about why that might be. Supported discharge, we've continued to support patients with or without COVID who've got existing chest disease out into the community. And in fact, we've continued to see some asthmatic patients within that cohort, which we wouldn't normally do. Oxygen reviews, so routine oxygen reviews have been done remotely wherever possible. And some will be delayed, but the acute oxygen reviews where Charlotte will talk about. And in addition to that, our consultant NDTs with Dr. Singh have continued on a fortnightly basis, which I think has been really important just to keep ourselves up to date. So as I said, admission avoidance is running normally, but the numbers are really short. Really small. Home oxygen installation has increased. We haven't had huge numbers, but what we have been doing is we've been going in earlier, so within 24 hours to do the initial review. And I think generally what we've found is that the patients have been quite complex and they've needed more input, but I'll leave Charlotte to tackle that. We are in the process of setting up Attend Anywhere so that we'll be able to do proper remote reviews with video, which if we can, that will really help tackle some of the waiting lists as well as the post-COVID patients. And as I've said, the supportive discharges continue. So in terms of what we anticipate seeing, we're all in the same boat, I suppose. We've never had COVID-19 before, but what we've looked at when we're trying to model what we might need is we've looked at the results of the SARS epidemic back in 2002, ARDS in terms of rehab and what the symptoms are for those patients, and we've tried to link those together. What we know we'll see is a huge spectrum of cases from mild to moderate, which in SARS it was 80% were mild to moderate, who are affected minimally and spontaneously recover with no problems, compared to patients who have long-term needs following long critical care admissions. And that's 50% of the patients who do end up going into ITU have not necessarily survived. And just looking at the SARS data, when they looked at it in Canada, all that they reviewed patients post hospitalisation, and at 3, 6 and 12 months they reviewed them, and there were a significant number in whom fatigue at 1 year was contributing to exercise limitation, and I think about 17% had not returned to previous employment. So it will be the whole spectrum, and I suppose from our perspective it's making sure that our energies are channeled into where they're going to be most effective. So in terms of the symptoms that we are coming across, they sit very much with what all the data out there shows. So breathlessness is an issue. General deconditioning, also an issue which we're hoping will respond to time and rehab. Slow weaning from oxygen therapy, and alongside that, significant desaturations with exercise, very much along mirroring what we see in ILD patients. Significant fatigue, and that's something that our therapy colleagues in the acute sector are very much saying, is that the difference from one day to the next can be so huge just based upon fatigue. It's not a weakness issue. Myalgia, increased sputum load and cough, which we expect will be an ongoing problem in many patients. And then there's also the psychological aspects of anxiety, depression, and signs of PTSD. What we're not seeing yet in the community side is the tracheostomies, which is probably because they're not yet ready for discharge, but that will become an issue. And the patients who are the long-term ventilated, they haven't yet reached the community, but at some point that's obviously going to become an issue, and where best should they be rehabilitated or signposted. I think just generally speaking, we expected to see all our familiar COPD patients coming in with COVID and probably not doing terribly well, but that doesn't seem to have materialized. And I think there may be aspects to that in our experience, they took the self-isolation very seriously, and a lot of them are very fearful, in fact, and will decline visits even if we offered them. So I think that's one issue. And we also wonder about pollution potentially, because that's been reduced over the period of reduced traffic on the roads. But one of the things that we don't know at this point is whether, in fact, they've been seen in primary care and they've had rescue packs galore, and we're not seeing that. So we're assuming that most of them are actually doing okay. We have seen an increase in asthmatic patients, but again, there could be a seasonal element to that. So as we head out of COPD viral exacerbation season, we'd expect a natural dip, and we would expect an increase in asthma at this point in the year. So I'd be quite interested to know really if there are any thoughts coming back around what's happening with our COPD patients in the community. I don't know if there's any points.
Yes, thanks. So we haven't got many questions coming through yet. Someone is ready and waiting for the trackies, which is, I guess, good news. I think you're right. I think the COPD patients in particular have really taken this to heart and are effectively shielding. I think they are staying indoors. They're not coming out. They're taking it incredibly seriously, which as they should. But we're not seeing, I think, correct me if I'm wrong, but colleagues in primary care, but I don't think we're seeing the number of exacerbations that we were expecting.
I mean, Phil, just to echo that, I mean, from a secondary care so I'm on a pan-London group, and this is not just local to Tower Hamlets. Actually, across London, there are initially are we not seeing COPD patients because they're shielding, staying at home and exacerbating at home? But actually, we're not seeing it anywhere, and I think even at home in the community, we're not seeing as many exacerbations, and we do wonder whether COVID pathology is slightly different to our normal respiratory viruses, where instead of having much more bronchospasm as we get with, RSV, rhinovirus, actually you're having much more lung parenchymal changes. So actually, even those patients that have had airway disease, and particularly COPD, coming into hospital, wheeze hasn't been a predominant factor. It's actually been marked hypoxia, sputum, chest pain. It's been a different presentation.
Thanks, Richard. And I think also, as Dan has just mentioned, that it's the same in paediatrics at the other end of the age scale, that they're not seeing coming through casualty cases that you might imagine. So someone has put a direct question to you, Jane, around the recovery time in terms of resaturation after rehab.
I think that will be covered by Charlotte. If maybe we take that then, or see if Charlotte covers that.
Fine. Okay. Well, let's.
Okay.
Let's
I don't want to step on.
We don't want to jump in too soon.
Okay. Fire away again then.
Okay. So I'll hand over to Charlotte.
So the next few slides are talking about kind of rehabilitation, really, kind of what we might expect, and then I'm going to allude to kind of from an oxygen perspective as well. So aware that a rehabilitation covers kind of a huge spectrum. The American Thoracic Society and ERS, kind of the European Respiratory Society, are in progress of developing some good practice guidelines. And BTS have completed a survey that looks at the essential components of rehab. So that's a multidisciplinary survey that went out a couple of weeks ago, and they were kind of compiling results from. So just seeing in terms of kind of what do we need in terms of rehab pathways. We're aware, obviously, there's a significant clinical symptoms that patients are going to be presenting with who would be amenable to a pulmonary rehab style exercise program. But from our team, we're under the impression that actually these COVID patients should be treated separately to patients that are already sitting in our existing PR program or the referrals that we've been coming in. So they are kind of presenting as almost like an ARD style survivor picture. So you will be expecting a natural recovery, hopefully in the first couple of months after discharge from hospital, or from kind of recovering from their symptoms. And then this kind of improvement might plateau out. And then it's looking at in terms of when we're picking these patients up, kind of what their signs, their symptoms are, and then making sure that they're pinpointed kind of back into the service, and we're picking them up from an exercise perspective. We don't want to be duplicating work, so we know that there's a lot of work that's going on from a national level, so it's kind of keeping our eyes and ears into everything that's going on at the moment, and obviously not duplicating or replicating work, but making sure that the services that we will be providing are going to be specific to this cohort of patients and their needs. So we know that rehab is highly effective in most respiratory diseases, but what are the opportunities to intervene kind of early in terms of kind of post-hospital discharge? We know from NICE guidelines and data, part of our sequence is obviously getting COPD patients into pulmonary rehab programs within kind of 4 weeks of discharge after an exacerbation. And it's actually looking at kind of, are we then going to let time intervene and give that gradual recovery to these patients over kind of 6-8 weeks, or are we going to try and get them in a little bit sooner, or leave it a little bit longer to see in terms of what happens in terms of their natural recovery? We need to think about what's the provision for patients that aren't hospitalised. The data that came out yesterday shows that from the Royal London Hospital, we've discharged 734 patients with COVID, and from Barts Health in total, we've discharged just over 2,000 patients. Obviously, we've discharged just over 700 patients from the Royal London. The high proportion of those are going to be Tower Hamlets residents. And then it's thinking about actually what's the follow-up provision if they are going to be symptomatic, or are we going to pick them up at a review point in terms of then tapping them back into services. We're obviously hoping that not 700 patients are going to need our services, but it's making sure that the right patients are going to be tapped into services where needed. So we're talking about kind of that initial first discharge. Patients that are leaving the Royal London and from Barts hospitals are given a COVID-19 discharge booklet that kind of gives them a general advice about managing their symptoms and kind of maybe what to expect over the next couple of weeks. So we're thinking about low impact exercise, functional exercises, so getting up from the bed, kind of walking to the toilet, sit to stand, things that you can do on the sofa, brushing your teeth, the functional things that you'd be doing as part of your everyday life, and kind of thinking about that for the first 6 to 8 weeks. We've obviously got concerns in terms of how we manage these patients if we're then thinking about them getting into a group environment. So knowing how long patients are contagious for, interactions that they're obviously having with family, friends, when lockdown restrictions are obviously reduced, the impact that might have as well. And then thinking about us in terms of, we already run pulmonary rehab within a community setting and at gyms within the community. Actually, is that going to be safe? Is it going to be a long-term viable option? Or is it that we're going to have to be doing this within a hospital environment? And from an oxygen perspective, we're seeing patients that are presenting similar to kind of an ILD picture. So they're desaturating quite quickly, taking time to recover. So actually, do these patients need to be assessed face-to-face? They need an actual walk test. We need outcome measures that show that they're desaturating. Is there any benefit for them having oxygen whilst they're exercising? Is there going to be a rush on ambulatory oxygen? And then it's in terms of kind of weaning patients if we're going to set them up on oxygen for their long-term management. We also kind of need to think then about the long-term psychological cognitive impairments of these patients. Those patients that have been in critical care, that have been on ECMO, had a tracheostomy, long-term ventilated, are they going to have the same care needs that patients that come into the Royal London and are turned around in a couple of days, or actually patients that have never needed to go into hospital and have been able to manage their symptoms at home? So it's thinking about kind of the extreme of patients, I guess, that we're going to be seeing potentially in the community. We're thinking about it as well in terms of from a multidisciplinary perspective. So a COVID recovery program, what we're thinking about what this will be in the future. So there's a lot of work being done by NHS England with a digital pulmonary rehab program that's looking to support and create open access as a recovery program. We're obviously mindful of our cohort of patients as well. Not all of them are going to have access to remote technology, laptops, equipment that they're going to need to be able to do this program and also do it safely and be monitored. But again, this is a work in progress through NHS England, so we're just seeing what happens from this perspective. We're thinking that exercise classes, the pulmonary rehab classes, are a broad space of MDTs, a significant kind of psychological space for patients post-COVID, or even the pulmonary rehab patients that we have now, that they're in a safe environment, that they're with people that have gone through a similar condition or a similar experience to them. We already have a dietetic and dietitian input within our PR classes, but it's looking in the talk from NHS England and other PRs kind of programs is there then input from speech and language therapists? Is there other kind of MDT members that we don't currently use that would be useful to have within that clinic, within that assessment and that education session as well? We're likely that we're going to have to increase our capacity to meet demand. So it's whether or not we're then going to be using digital solutions as well as doing face-to-face pulmonary rehab. And I guess we'll kind of talk about kind of post-COVID as we go down the line in terms of where do we deem it appropriate that a patient then does a digital class as opposed to something that's face-to-face. We need to make sure that the programs are real, and if it's an alternative solution, that it's digital, that it's actually something that is viable in the long term, a valuable solution, but we're obviously mindful that this is going to take a little bit of time to set up. We need to make sure that we've got close links across all care providers in primary and secondary care. And as I've alluded to, we think that they should sit separate to the existing pulmonary rehab program. So we're mindful we've got 200 patients on our wait list at the moment without any new referrals that might be coming in over the next few weeks. So it's supporting those patients and the COVID recovery ones. We're likely to pick up patients that are post-COVID pneumonia, so when they're reviewed virtually at a chest X-ray, potentially on kind of 6 to 12 weeks after they've been discharged from the hospital, if they've been tapped into then kind of respiratory medicine or secondary care. but we need to kind of stratify those that actually need the rehabilitation and need this program based on their severity of their symptoms, comorbidities, their kind of psychological well-being as well. Have they got access to the digital technology, and actually what's their preference? We're thinking then about an opportunity then for these patients that might not necessarily screen in at 6 to 12 weeks by an X-ray that they've got a COVID pneumonia, that then there's another point in terms of 6 months at an MDT clinic, which again is a work in progress, or whether or not then these patients might be picked up within primary care and at a GP situation when they've come for their asthma review or a COPD review, that actually they've kind of disclosed that they think they've had COVID, or I guess if and when antibody testing comes out as well, that might be another kind of consideration to refer patients in. So the referral mechanism is kind of ongoing, and I guess is going to be up for discussion. There's also discussions about breathing pattern disorders, so dysfunctional breathing that might be a long-term consequence, which kind of needs specialist input from respiratory physiotherapists and kind of the best point in terms of treating these patients. But this will be something a lot further along down the line. So,
there's a few questions come up. I don't know if I can just butt in a little bit. Someone has asked around, about a few people have noted about the discharge booklet and how useful it would be to get a copy of it or access to it if that's possible.
So
if you just confirm with Neil, because it's all gone through Neil, but I'm sure Neil will be fine with that. I would just double check that he's okay for it to be passed around. Okay,
and I guess that might be very useful for those patients who haven't made it into hospital but that we've been treating in the community.
Yes, absolutely.
To rehab in the community. And there's a point from Saida. I suspect that this is probably more directed towards yourself, Richard. Saida, do you want to unmute yourself and just ask that question?
Or shall I read it out?
Okay. Saida, do you want to ask it? You're unmuted now.
Sure. Can you hear me?
Yeah, absolutely.
Okay. So my question really was that given that on a daily basis we're hearing about spare capacity in the NHS critical care service and also on the Nightingale ward, that could more lives have been saved if more patients were actually admitted at an early stage of their COVID symptoms, rather than to be told constantly by the NHS one-on-one and others to not to go to A&E until your symptoms become much worse. I just find it really quite demoralising to hear these numbers increase now to above 30,000 now. Is there any evidence for early oxygen treatment to save more lives?
I mean, aside, I think there isn't any evidence at the moment. I think one of the things is that there is capacity now. There was certainly not capacity at the start of the pandemic. So, for example, at the Royal London Hospital, our team ended up having to run 2 respiratory HDUs on what would have been normal respiratory wards, doing what is essentially high dependency care and normally carried out in critical care on the normal respiratory wards. Plus there was actually, as it was reported in the news and across lots of sites, actually the availability of oxygen within acute trusts. We were not expecting the numbers of people obviously needing to come in and needing not just 1 to 2 litres of oxygen, but needing high flow. And actually there wasn't enough oxygen. At the Royal London we were actually not too bad, but even at our sister sites it was reported at Watford that patients didn't have enough oxygen in acute hospital trusts. I think Nightingale was it came at the right time, but by the time it was set up, actually the numbers were starting to decrease. It wasn't just about the number of beds, it's about staffing, it's about nursing staff, and they had to turn away a lot of patients because they didn't have enough nursing staff. So I don't think it's as simple as saying it's just about oxygen.
No, but if we did have sufficient staff, do you think, in theory, perhaps when
I think we're making a lot of assumptions. I think that's very difficult. It's not just about staff. It's also about CPAP capacity, Optiflow capacity, intubation capacity. So it is not just one thing. It's, it always is. It's never just one thing.
No, but potentially more lives could have been saved.
I'm saying that we just don't know.
Oh, okay, thank you.
Okay, great. So on to oxygen.
So I look after the oxygen service. So this is a community service that is already existing. So in terms of from the evidence that we know, and I was provided from NHS England, so any patients that have long-term oxygen at home, so these are any patients with oxygen but not the cluster headache cohort of patients, were asked to be identified as shielded. So that was a bit of work that was done in terms of every GP practice, if they've got oxygen patients, were notified in terms of their oxygen patients. They've all been registered with NHS Digital, so that if they need access to, so they're registered as vulnerable, so if they need access to shopping or other bits and pieces, that they are now coded accordingly. And I'm aware, obviously, GP practices have done this, and thank you for doing this as well for your patients. In terms of new referrals, so the same principles apply in terms of the British Thoracic Society and NICE clinical guidelines apply for new patient referrals. So this follows the same situation in terms of on the wards and looking at patients that are going to be discharged. So we're looking at ABGs, blood gases that determine that a patient is hypoxic, unless we're supporting a palliative or a compassionate discharge home for a patient, in terms of looking at them being at home for their preferred place of care, in terms of supporting their death. And this is something that we do routinely as a service, and that we've continued to kind of provide throughout this pandemic. We're aware that treatment for hypoxemia, its options are as a treatment for hypoxia and not breathlessness. So there are multiple kind of management strategies that a patient should be trialing first, as opposed to oxygen therapy. And in terms of what, from a service situation, we're then looking at in terms of patients that have now gone home on oxygen, as James alluded to, they've been given a phone call within 24 hours, kind of a telephone consultation, a home visit if it's been deemed appropriate from a safety perspective, or there's other concerns. And then the outcome of that consultation has been a letter that's been gone to the patient and to the GP to advise them now that they've been set up on home oxygen. They need to be registered as shielded if they weren't already, and in terms of kind of what the ongoing follow-up is. The contraindications for home oxygen have remained the same. So patients that are active smoking don't meet the criteria as per NICE and BTS guidelines. But kind of the considerations for COVID have come out through the London Clinical Network guidelines. So oxygen isn't there as an emergency response, home oxygen. If you've got patients that are deteriorated at home, that have desaturated, and if for admission to hospital, that is the route that they should continue to be taking. We're not an admission avoidance service for oxygen in terms of we're going to go out to patients' home and put it in immediately. It should be done through the same channels that a new patient referral would be done. My kind of perception of how the service might be going forward in view of COVID is in terms of the considerations for ambulatory oxygen. So these are the patients in line with kind of the COVID kind of rehab pathway that they might be going through, that they're going to be, that they're potentially desaturating and they're symptomatic when they're doing functional exercise. And then it's looking from us in terms of as clinical specialists, the right device in terms of oxygen to be giving them, the education, the ongoing follow-up, the doing capillary blood gases, so airway blood gases in the community, and then the safe removal of oxygen when it's deemed appropriate. Unfortunately, with COVID or at this time of year, we have seen a reduction in terms of oxygen patients within the community. So there have been nearly 15 deaths over the last 2 months. Whether or not that's in response to COVID as well, or these are patients that were palliative and they've unfortunately passed away. But there has been a kind of a significant, I think, deterioration in those patients. But similarly, the referrals have gone up, but it's like James alluded to, it's supporting more complicated discharges from the ward, and it's not only patients within Tower Hamlets. The Royal London and Barts have seen patients across all CCGs, so Hertfordshire, and just kind of supporting from that perspective. Is there any questions? I imagine there is about oxygen.
So there's one question that's come through from Dan Gibney. Dan, do you want to ask that yourself?
Yes, can you hear me?
Yes.
Yeah, so I just wondered how many new patients you've had post-COVID that have got new sort of health requirements?
So from discharges from the ward, that from a Tower Hamlets perspective that I've been aware of, there's been one, but that was an ILD patient who had COVID, but I think would have met the criteria for having home oxygen anyway based on blood gases. But that's one patient, so it hasn't been a considerable increase.
That's interesting. Thank you.
Yeah.
Thanks. And you think in terms of excess deaths, how many? I know it's a dreadful thing to think about, but what would you normally expect in an average March or April?
Typical month, you're probably looking at about 3 to 5 deaths. I wouldn't say I'm necessarily surprised by the names of patients that have passed away. They have been patients that have had palliative oxygen or have significant comorbidities. But I guess some of them have passed away a little bit sooner than potentially we would have liked.
Thank you.
All right.
Yep. Do you want to carry on?
Yeah, we'll carry on. So I don't think what we thought might be helpful is just some quick self-help tips for some of the patients who maybe you would see. So this part will be really brief, but we find that the vicious cycle of inactivity is really useful with patients if you're trying to encourage them to do a little bit more. So that's quite a nice resource just to get yourself slightly fitter. We know that breathlessness is an issue with these patients. So we'll go through a couple of positions for positioning, posture, pursed lip breathing. So breathing in through your nose and then out through almost closed lips to try and keep the airways open on expiration. So that can be quite a nice technique. A lot of patients do that naturally. Breathing exercises, so rectangular breathing is quite a nice technique. Patients will relate to that if they're used to watching television. So you can breathe in through the left-hand side and then breathe out as you look along the top of the TV and then in as you go down. So essentially you're trying to normalize their breathing pattern so that inspiration is shorter than expiration. Coordinated breathing training, again, that's just more of a relaxed breathing technique. In COVID, we don't recommend, we shouldn't recommend the use of fans. That is the one different thing from general advice around breathlessness, but good room ventilation, cool rooms rather than warm. And then the other thing which can be quite helpful is the calming hand. So these are just a few positions that can be helpful just to show patients if they're experiencing breathlessness. Oh, I've gone the wrong way, sorry. Oh, sliding twice. Sorry about that. And then there's the calming hand, which was developed up in Cambridge by the Breathlessness Intervention Service. But this is something which is really nice because it also works on your mental understanding as well. So in this, you get yourself in a position and you squeeze the base of your thumb, the nail bed of your thumb, just whilst you acknowledge what's happening with your breathing. And then once the patient's managed to do that, then they hold on to their index finger as they sigh out. They inhale gently as they hold on to the middle finger. Exhale gently as they hold on to the ring finger. And then at the end, you stretch your hand out and then try and think about relaxation. And you can go through that process as often as necessary, but your hand is always with you, which is if someone is experiencing breathlessness, that's why it's a really nice technique to show patients. So this just really summarises thinking about fatigue. So making sure that you spread out your activities throughout the day and manage that, and also sleep hygiene around sleep being really important. And when we talk to patients about increasing their exercise, we think about the FIT principle. So how often they exercise, the intensity of the exercise, how long they're exercising for, and what type of exercise it is. So that's something that we would, so if patients want to know how do I know whether I'm able to do more, then try and do, if you're doing sit to stands, just try and do a couple more each day, or extend the time that you're exercising for. And as Charlotte said, we expect that in the first 6 to 8 weeks there'll be a spontaneous recovery. So during that period, just advising patients just to do functional exercises, Charlotte alluded to, low impact, and just incorporate it into everyday life. When we advise patients on how intensive the exercise should be, we usually will be using the Borg scale, which is a 0 to 10 scale of breathlessness, and we would expect patients to go into moderate breathlessness, but not beyond that. So I'm now going to hand over to Ruth, who will cover the psychology.
So in terms of the psychological implications, the British Psychological Society has produced some guidance for people who experience severe COVID-19 infections. But I guess most people who have had COVID, whether they've come to hospital or not, will have there have been psychological implications. Obviously, we'd expect the usual adjustment phase after people have been through COVID and being particularly unwell. Anxiety, low mood and loneliness, we would expect. People are likely to feel frightened, on edge, hypervigilance to their bodily symptoms, difficulty sleeping, fatigue, and we are particularly aware that there's some cognitive implications for people who've been on, certainly on critical care, which we are going to be keeping an eye on in terms of the pathway. Particularly associated with COVID, we've got that notion of fear of stigma of an infectious disease, worry about contaminating others, whether that's happened or not. Obviously, bereavement's going to be in there as well, and some survivor guilt about people who maybe have got through when other family members haven't, or they've heard of other people that haven't. In terms of what we suggest, that this sort of normal psychological response is that these symptoms you usually expect them to settle between 6 and 8 weeks, but you would probably do this anyway in your practice. Suggest people stay connected, suggest people have a daily routine, to do things to focus on things that they enjoy at least once a day, and to try and focus on the present rather than getting caught up in the past or anticipate what might happen in the future. In terms of people who may need an onward referral psychologically, we're anticipating that hospitalisation may well be a risk factor, and the cornucopia of stuff that happens when you're in hospital, whether it's ventilation. We're quite curious about people who are admitted to hospital and then stepped up to ventilation. That anticipation of being intubated may have a longer term impact in terms of post-traumatic stress symptoms, or may not, but also some people would have witnessed both the death of other patients, proning, those sort of experiences, which seeing that happen to other people is quite, there's quite a lot of people around the bed when that happens. People may have memories of that. And obviously barrier nursing is quite difficult in terms of reading facial expression. So that ICU experience we anticipate may, for some people, lead to longer term need for some psychology input. Pre-existing mental health problems and psychological distress may also mean people need additional help, and of course bereavement. In terms of referral, you have your own Tower Hamlets Talking Therapies. They're gearing up to provide particular services around COVID. You may well know this, but they've got a computerized CBT form for it's about focusing on getting space from COVID. In terms of the actual progress at the moment of coping with self-isolation, coping with health anxiety, and managing long-term conditions when self-isolating. I put the details on the slide of the critical care follow-up clinics at the Royal London and St Bartholomew's. There are clinics at Newham as well, and there will be at Whipps Cross. We're increasing the capacity of the critical follow-up care at the Royal London. So currently it's once a month. It's going to be weekly for a while because we have so many patients to get through. And the bottom link there is for bereavement services for your patients. Thank you. Okay.
Thank you very much.
So I think that's more or less it. But I think you can see that from our perspective and probably yours, there are still a lot of questions that we haven't got the answers to. But what we would do is I think it's important that we keep in touch, and if there's any questions that you have for us as a service, then I've put our details there. And happy to talk through any problems. And also I've put down there the British Lung Foundation, which is a fantastic, I think there's so many resources out there, but it's a really sound resource for advice from a physical rehabilitation point of view, particularly around exercise, breathlessness, etc. So that's probably the one that I would recommend if you want to pass that on to patients.
Thank you very much. I'm just looking at the questions. Sorry, I'm muting myself. I'm just picking up a few from the WhatsApp group. Going back to the spirometry angle, one of our practice nurses has written in, obviously, we're not going to be trying any spirometry and surgeries for a while. Is there any advice on this? I know you mentioned that you were thinking of reintroducing spirometry. What are the issues around that for you? What decisions are you taking around when and how you might approach something approaching normal, whatever that is?
Yeah, we're being guided very much by, we're working with the lung function lab at the hospital, but also by the guidance from ERS, who have suggested different levels of risk, depending upon how virulent the COVID is in the community. So we're basing it very much on that, and we're also risk assessing so that when we do restart it, we'll have to think about personal protection, but also we'll only be able to have one patient in the lab at the same time, so that will slow us down. And we will also have to screen the patients, obviously, in case anything has changed from when they were referred to when it is that we're proposing. But it is something that we can't get away from doing it face to face.
I think, Jane, just to follow up on that, I think there will be similar restrictions that will be both in secondary care and in primary care with respect to spirometry. I mean, if any of you have actually done your lung function, which I definitely have, it makes you cough, and so it is an aerosol generating procedure. So even for those patients that we will screen, obviously there is that risk. So it's making sure correct PPE is available in both locations. And it's ensuring that it's not just about the patients and the staff, but actually in the environment and what do you need to do in between patients. And the current recommendation, I mean, we were on a conference call about this, suggests that we might only be able to do 4 lung functions per day instead of our usual. I mean, that is not going to be feasible when we're going to be assessing patients for breathlessness, maybe with persistent chest X-ray changes at a later point, where actually lung function becomes a big part of that. Is it because this is an ARDS straight lung fibrosis type picture? Are we actually just highlighting some underlying airway disease that we haven't actually picked up before? We just don't know, and so we have to find a mechanism that it's safe. We can start bringing back capacity, but it has to be pan-London, it has to be national, that we're doing similar things, and it's not just based on postcode. I think that's really important.
Thanks for that. So a plea, I guess, to keep us in the loop, and when we're deciding ourselves to go back to testing in the community, it would be really useful to learn from the guidance that you have and to publicise that widely, so we don't put ourselves or our patients at risk. Going on from that, the second part of the question was, how do you feel about the necessity these days in the COVID or post-COVID or even peri-COVID world around how necessary an annual FEV1 is for patients who are in the mild to moderate category, and is there some way of guidance, or is guidance coming out about maybe going to a 2-yearly interval? Is the next question.
Well, I think from my point of view, having done lots of MDTs, I think what's really important is that we do spirometry for a reason, and we're not doing it as a tick box exercise just to say that we've done it. It has to be done as a clinical management point. And I think it may be that you'll have patients that have been stable with very little in the way of symptoms, and actually, is doing spirometry going to change their management? Probably not. But those patients that are having frequent exacerbations, that are maybe still smokers, that aren't engaging in the non-pharmacological treatments, actually this is an opportunity to show them your lung function has decreased. These are the interventions that we can use. So, I mean, I find lung function very helpful in a way to help me guide trying to change treatment. And a lot of that is actually my non-pharmacological treatments, because we know that they're the ones that patients are more resistant to. They want a treatment, they want a physical drug. And so if I can at least show them something else, I think that helps guide them. But again, this is, we're all still in very much unknowns about COVID. I mean, really, we're only 6 weeks from when this, or 7 weeks from when this really kicked off. And unfortunately, it's a real shame that data from China and Italy doesn't have a lot in terms of discharge and what happens in that recovery period that we can extrapolate on. So we don't really have a huge amount of evidence that we can guide ourselves. So we're all learning, and I'm sure there'll be ongoing lots of discussions that we will disseminate as soon as we know any more.
So watch this space, really. And
I'll keep you posted.
Yeah. Okay. Good. So thank you very much. Thank you very much to all our 3 presenters so far. Jane, Charlotte, and Ruth. And now, Richard, do you want to go and coming up to the bits that you wanted to talk about on the post-COVID secondary care clinic for respiratory, and maybe deal with a little bit around chest X-rays and everything else.
Sure. So, I mean, we've realised that there's obviously a very big need for follow-up of our post-COVID patients, and that what's really important is this is not just predominantly about secondary care. You and your teams have managed huge numbers in the community. So we're faced with problems because, as Charlotte's already alluded to, we've had over 2,000 patients being admitted to Barts Health. And so what we're trying to work out is how we can accurately and as safely as possible review them, and using virtual reviews, highlight any problems, particularly that happen during admission, and then direct them to the appropriate services. Because what we realized during the absolute crisis of the pandemic is actually it was get people safe to discharge, but actually thinking about slightly abnormal liver function tests, slightly abnormal kidney function tests, anyone that's had clots, those ongoing follow-ups. So we are desperately in the last couple of weeks trying to set up a post-COVID patient pathway, where what we're hoping is that we're going to have access to both obviously inpatients, but actually an ERS referral into the clinic from primary care, so that about sort of around 8 weeks, if patients are still symptomatic, then actually they can be fed into our pathway, which once it's been finalized, I will share. But essentially what will happen is patients will be invited to have a chest X-ray. We need to have a dedicated site probably for that, and also to complete online questionnaires that will basically address holistic issues such as depression, anxiety, breathlessness, cough, also just about their quality of life, and smoking. And at that point, after they've completed those, we'll actually do a virtual clinic where, using the questionnaires, we'll look at blood results, and we'll basically be able to highlight and pinpoint sort of certain areas that either patients don't need to be seen face to face, their X-ray's fine, they are slowly recovering, but actually we can send them some links to online rehab, or maybe they need a breathlessness service that is physiotherapy based. So there'll be lots of different pathways, again, linking in hopefully to renal and to the liver team if there's ongoing issues from that. If the patients still have anything that we highlight at that virtual clinic review, particularly abnormal x-rays or ongoing breathlessness that we're concerned about, then they'll be invited for a face-to-face review. And at that time, we hope that to be a holistic clinic where we'll also have physiotherapy, so we can actually try and address whether there's any breathing pattern disorders, decide whether patients need hopefully lung function and CT scans when indicated. Whether we can do this as a one-stop shop, which would be great, I just don't know whether that's going to happen. So there is definitely a pathway being set up, that one that the primary care can refer into. I think the other question is, this obviously doesn't address the kind of immediate post-COVID concerns. You've got your hot sites, which are obviously in patients that are acutely unwell with likely COVID, and I think people worry about PEs. We had an email from one of our local GP colleagues about the prevalence of having PEs, and I think there isn't anything specific other than what we would do as standard. So you're looking at your heart rate, you're looking at your saturations and desaturations, and if you are concerned, then the pathway is still ED. We do have advice and guidance that is being set up so that actually the team can get back to you. We particularly did it as an advice and guidance rather than a telephone line, predominantly just because people weren't available to be on the line straight away. So hopefully it means that during this period of unknown, there can be support. And then I've said to Phil, I'm very happy once we get the pathway finalised, we can try and share that with you. I can make sure that you know what the ERS link is, so that you can refer to the correct service.
Wonderful, thank you very much. In terms of, just to re-emphasise the issue, in terms of if we want these days to try and arrange a chest x-ray for someone from the community, is there was some discussion a week or so ago around how best to do that for the patient as well as, so the patient who is coughing, who you're not sure whether they've got COVID or not. This cough has been going on for I don't know how long. The normal thing you might do clinically would be to arrange a chest x-ray, but of course you don't want to put the staff at the hospital at risk. Is there a way, a pathway in? I know there was discussion about via casualty, via the x-ray department in casualty, but do you have any comments on that, or is that something that I just need to go and look up?
So actually, I don't know what that is from a primary care point of view. I think that's really important. I think that you need to have the ability to review a chest x-ray, because ultimately if patients are getting worse, then what is the cause? And I think what we don't want to do is become so blinded by COVID, we actually forget about other diagnoses, and you get sort of diagnosis fatigue. And I think that's why a chest x-ray becomes so important. Let me see if I can do some digging. So I'll email the head of our radiology department just to kind of see what advice there is.
Thanks. I know that there's been a little bit of conversation around it, but if put it out later. Otherwise, I think I should probably just do the legwork and go digging back into the WhatsApp group. But if you did have the findings, then that would be great too. Good. Any more questions coming in? I can't see anyone that I've missed out, but if anyone does feel that I've missed out putting their question, can you raise your hand or just put a note in now? Okay. So, perfection in terms of timekeeping, ARCaRe and respiratory, bang on 7:29. So it just leaves me to say thank you very much indeed for coming along virtually and giving us the talk. It's certainly I've taken a few things home, and I'm sure everyone else does too. Oh, there's one question just coming in. Sorry, I spoke too soon. Ruth, do you want to unmute yourself and just ask you a question about monitoring?
Thank you. I just was wondering, we were musing over, I don't know if you know much about it, but we have put in the home monitoring service so that we're contacting people every day who've got positivities and assessing needs for that cohort as part of the keeping people out of hospital kind of plan. We've been doing that for a couple of weeks now. We've had some good success. We're looking at an audit on that. But we're just reviewing kind of the recent emerging evidence around the VTE risk and thinking about how we might use that service going forward if there's an increase in VTE risk. And I wonder if there's any advice or guidance around that.
I mean, from my point of view, that's not something that I've been involved with specifically, particularly the VTE pathway. There probably is, however, in terms of what's the best, because it's really tricky. I think that I think we have to bear it in mind in terms of post-PE VTE. They're not really DVTs that we're getting. They seem to be a different pathophysiology. And it's, you know, the patients that we've seen have generally been subsegmental, so a little bit smaller. And it's a little bit unsure of, if we don't catch them early, what's that long-term significance? Because again, it's slightly different in terms of the pathophysiology. So my colleague, Will Rickett, I don't know whether he was on this call. I don't know whether he's still on. I think he's on call today. And my colleagues in haematology have been looking at that side of the pathway. So it's not something that I specifically know, and I don't want to give advice right now, but I think it's something that's worth thinking about.
That's great. Thank you.
Okay. Thank you very much. Good night, everyone, and stay safe.
Thank you.
Thank you.
Thanks, everyone.